welcome to another Tidepool for Telemedicine webinar. This is going to be fun. Dr. Adi's here. Hi, Dr. Adi.
Hello, Christopher.
How are things?
Oh, excellent. It's nice and cold and foggy in San Francisco.
I have no idea what cold and fog feels like in Atlanta, Georgia. All right, so this is going to be a fun day. We're going to get right to your contribution, which is basically why everybody's here, to learn about how Tidepool can help patients optimize ISF and insulin-carb ratios. As a reminder, we're not here to give specific medical advice. If you have questions like, this is what my ISF is, here's some information, what should I change it to? We're not here to answer that. We're here to offer tips on how to interpret data to make those changes in consultation with your medical team. As a reminder, my name is Christopher Snyder, Tidepool Community Manager. Dr. D is here. He's a Chief Medical Advisor at Tidepool, one of the co-founders. He's on the board. He's awesome. And that is that. As a reminder, diabetestelemedicine.org is the place to go if you have any interest in using Tidepool for telemedicine visits. We've got resources for clinicians, resources for patients, links out to webinars and things like that. All sorts of good, fun stuff there. diabetestelemedicine.org. When in doubt, send an email to support@tidepool.org, and that will come back to me or a number of other support people. We actually hired a new support person as well. You might actually find Kyle. He's new. But yes, if you ever have a question about Tidepool, support@tidepool.org is the place to go, and we will get back to you as quickly as possible. It's go time, Dr. Adi. The people have spoken. They want to hear about this stuff. I'm going to stop sharing my screen and let you take over. We're going to have ourselves a fun conversation.
Thank you very much, Christopher, for that very nice and generous introduction. Just for the rest of the participants, welcome. Thank you for joining us this morning. You will notice that I speak almost at half speed of Christopher's. Hopefully
I get so excited when we do these things. I can't help it.
Yes, I know. That's all right. So I'm just trying to navigate here. I need to share my screen and then go to the other window as we practiced this morning.
Perfect.
And you got it right there. That's the title slide. You can see it, Christopher?
Yes, sir. We're good to go.
All right. Very good. Welcome, everyone, again. And thanks for joining us. This is going to be fun. And hopefully, we're going to go through some slides about assessing and calculating the insulin-to-carb ratio and the ISF, and a process of optimizing those two. So as Christopher said, I am a pediatric endocrinologist, so almost everything I do is in pediatric diabetes. So there's a lot of perspective from children, how we do things in children with diabetes, but almost all of it will apply to adults as well. I don't really have a sense of how many of you are related or caring for children versus yourself, but I think hopefully it will all be relevant and useful. All right, just navigating the buttons. Here we are. Our objectives today are very simple. Provide some guidance on the insulin-to-carb ratios, and we're going to call them ICR or insulin-to-carb ratios, and the ISF or the insulin sensitivity factor, also known as the correction factor, which means that if your ISF is, for example, 50, that means we're expecting that 1 unit will drop your blood sugar 50 points. And just so we eliminate some confusions about, which is very common when we talk about ISF, is it increasing the ISF or decreasing the ISF? So I'm actually going to try to avoid using those terms and instead use the terms of weak ISF, meaning it's not enough insulin, or strong ISF, which is giving too much insulin. And the same thing for ICR also. It's a weak ICR, that means we need more insulin, or if it's a strong ICR, we need a little bit less than that. And our second objective is really to sort of show some real life examples of how to assess and calculate both the ICR and ISF. And I think that's probably why most of you are here and want to see some tips on that. Optimizing the insulin-to-carb ratios in the ISF is a process that really should be a step-by-step process and just take it one step at a time. And ironically, when we're talking about ICR and ISF optimization, in my opinion, the first step in optimizing those two is actually starting with optimizing the basal rate and the basal to bolus ratio, because we need to have a steady functioning and adequate basal rate in the background to isolate the effect of basal rate from the effect of boluses for the carbs and the corrections. So that way, we can actually just focus on the effect of the boluses for the carbs and the for corrections and optimize those. So in order to get there, as you will see in a few slides, we really need to work on the basal rates first, which is something that we've covered extensively in a separate webinar. And I think at the end, maybe Christopher and Suzanne can give you the links to those as well. But today we're going to focus on just the ICR and ISF. But again, the first step is really to have a good solid basal rate that's working very well in the background. And then the third thing is finding pure events. And that's key for assessing and calculating ICR and ISF. So what is that? We're going to get back to that in just a couple of slides and show you what I would consider to be a pure event that's going to be essential for working on the ICR and ISF. So before we get there, just a few general comments. In my opinion, and particularly in children, again, data review and adjustment should be done frequently, like every 4 to 6 weeks in children, maybe much less than that in adults, obviously, because they don't change that much. But if you're dealing with children, I think it should not last more than 6 weeks at a time, and then the data should be reviewed and the settings should be adjusted for both the basal rates as well as the ISF. And primarily for the ISF, because the insulin-to-carb ratio, in my experience, does not change as frequently as the ISF. The ISF and the ICR changes don't go always together. So oftentimes, you might need a little bit more for the ISF as the child continues to grow and get older and change. We need stronger ISF continuously adjusting. But the insulin-to-carb ratios may or may not change in tandem with the ISF. And typically, the ICR actually are more stable than ISF, even in children as they grow and change. What I found over the years is that the insulin-to-carb ratios don't change that much. In fact, they are really stable across all ages. So one example I'll illustrate is that one would think that if an ISF, for example, is 40 in an adult and the insulin-to-carb ratio is 15, so 1 unit for 15 grams, and 1 unit will drop their blood sugar 40 points. That means if we take a child whose ISF is 400, one would expect that big difference between the insulin sensitivity in a child versus an adult will also translate into a big difference in the insulin-to-carb ratio, and the answer is no. Actually, the insulin-to-carb ratio in almost all children and all adults would be about the same, with some variations during the peak of adolescence. But otherwise, 1 for 15 grams, just like it works for most adults, 1 for 15 grams also works for most children. It's the ISF that changes dramatically. That's very different between adults and children. And then even with closed loops, we still need to optimize these settings. So I hear a lot of people saying, with closed loop system that's going to adjust blood sugars continuously all day, do we really need to optimize the insulin-to-carb ratio and the ISF? And my answer is yes, because the better those ratios are set, the more effective the closed loop system is going to be. Remembering that most closed loop systems are going to predict what the blood sugar is going to be in the near future, in a few hours from now, and then calculating how much extra insulin do you need. And that calculation is taking into account what the ISF really is, the ISF that we told it should be. So it's taking into account that ISF for calculating how much extra insulin to give. If we don't have an optimized ISF, then the closed loop system is not going to be as effective, and it's going to be chasing the blood sugar all the time.
So Dr. Adi, to that point, I just want to let you know, in terms of response to our poll question, do you currently use an automated insulin delivery system? Overwhelmingly, 72 out of total response, 69% of responses that have come in so far say yes, they're currently using automated insulin delivery system. 12% are indicating their healthcare provider. So looks like most of the people there, hi everybody, are actually people with diabetes or caregivers that are using these systems directly. So I don't think that's going to necessarily change how you're presenting your information, but in terms of knowing your audience, there you go.
No, it's great to know. Thank you for that, Christopher, because I think, a lot of the slides and real life examples nowadays are coming from patients who are using automated insulin delivery systems. So I just wanted to make sure that everything is relevant. And the way we look at the data and finding those pure events, as you will see, are a little bit different in a person who is using an AID versus a person who is just using a sensor augmented pump. So when we're talking about the main settings, just to put it in a larger context, the main settings that I think about for both people who are using an automated insulin delivery or not is the basal insulin, and then the insulin to carb ratio, the ISF, the insulin duration time, and then the use of extended boluses and adjustments for exercise. And that's true even for people who are using automated insulin delivery or closed loops. And then the other thing that I always like to focus on and find and discuss with the patients and the parents is the low treatment index, or how many grams of carbohydrates do you really need to raise your blood sugar or to prevent a low from happening. So knowing, for example, for the ICR, like how many units of insulin do you need for the carbs, or for the ISF, how much would your blood sugar drop with 1 unit of insulin? I think it's equally important to know how much would your blood sugar rise with each gram of carbohydrate. That gives you a very good solid guidance as to how many grams of carbs do I need when I'm treating a low blood sugar, so we're not overshooting and ending up and down. But today we're only focusing on the 2 of those settings. And if we have time, we can talk about the insulin duration time as well, because it's sort of integrated in those pure events as well. So a few helpful hints before we dig into some examples. One is that the ICR for breakfast is almost always stronger than the rest of the day. Just remembering that most people will need more insulin for breakfast carbs than the rest of the day. And what works for lunch may or may not work for dinner. Most of the times, again, higher insulin for carbs for breakfast only, but the rest of the day, all day, lunch, dinner, and snack is almost the same insulin to carb ratio. Most of the times, again, in some people, they might actually need a little bit more for dinner. It depends on what else is going on. But they may need a little bit less for dinner, or the lunch will be a little bit higher or a little bit lower. But most of the times, I would say, just to keep it simple in the beginning, in general, more insulin for the carbs for breakfast, because the body is more resistant to insulin at that time. And then the rest of the day, 1 insulin to carb ratio should work okay, at least to start with. And then, like we said, again, to iterate that the insulin to carb ratio does not change much with age. It might actually be, 1 unit for 20 grams in an infant, or 1 unit for 25 grams. But then it changes very slowly to get to 1 unit for 10 and 15 grams, as opposed to the ISF, which can easily be 1 unit for 500 in an infant, changing gradually over time to reaching adults, 1 unit for 40 or 1 unit for 50. And finally, the last hint is that the ISF, and this is important to remember, should follow the basal pattern, because they both reflect the insulin sensitivity. As the name indicates, insulin sensitivity factor. As we have seen in our webinar about basal rates, that the basal rates during the day follow a particular pattern, where at certain times of the day you need more insulin, and at certain times of the day you need less insulin, because you're more sensitive to insulin, so you need less basal rate. And the same thing applies to the insulin sensitivity factor. It should not be the same all day, 24 hours. When you're more sensitive to insulin, you need a weaker ISF, and when you're resistant to insulin, you need a stronger ISF. And here's just to remind all of us of that basal pattern that I was talking about. For example, in a prepubertal child, when we see that the basal rate here illustrated in the blue line it sort of dips down here right after midnight because you need much less basal, and then gradually increases at 6 or 7 a.m. to reach a peak here. And then it comes back down for the rest of the day until they go to sleep. Right after they sleep, the first half of the night, they need a much higher basal, and that's actually the highest basal of the day because they are very resistant to insulin. They are most resistant to insulin during this time here. That's why they need higher basal rate. And to follow that in parallel, actually, that's the numbers, the green numbers here for the ISF. So for example, if the ISF is about 1 unit for 200 points at noon or during the daytime, then obviously they need a lot stronger ISF here because they're resistant to insulin. And it could be as much as 160 compared to 200 during the day. And the same thing here for the second half of the night, right after midnight, when they need much less insulin for basal, but they also need a much weaker ISF because they are very sensitive to insulin. And you can follow that up here as the peak here and adjusting the ISF as well. And you will see that here, for example, in post-pubertal or most adults as well, the same pattern here, which is a peak of insulin requirement because they're resistant to insulin in the morning around 6 or 7 a.m. And that should be the strongest ISF here. And then during the day, it goes down, the basal rate goes down, and the ISF becomes weaker as well. And remember this here, right after midnight, this is true for everybody, children or adults, is that they're more sensitive to insulin right after midnight, between 1 and 3 a.m. And we need to have the weakest ISF right here. So a single ISF all day is probably not a good idea. And we need to follow the same pattern of the basal rates to create at least 3 or 4 different ISFs for the day. All right, what about the concept of pure events? Again, I'm going to spend just a couple of minutes on this because it's really important. In order to assess and calculate ISF and ICR, we need to look for those pure events. And there are 4 different criteria that will make a complete or a really good pure event, or a pure event. One is that it's a single dose for a meal or a correction. And the second is that it's preceded by a stable CGM trace for at least 1 hour. So CGM tracing meaning blood sugar that's not rising and it's not dropping, it's just stable. It doesn't have to be in range. It can be anywhere, but at least it's stable for a minimum of 1 hour. And then the third criteria is that it's followed by no other events for 3 to 4 hours after that. So there's no more snacking after that, no carbs, no boluses, no corrections, and no exercise. And you can be getting the sense how difficult it is to actually find those pure events, and particularly if you're dealing with children. But we do the best we can. And then finally, it's a good stable basal rate in the background. So the changes in the basal rate are not contributing to the changes in the blood sugar. It's purely an effect of the bolus that we're giving. And that's how we're going to focus on, is the bolus enough or too much or too little? So we need to have that basal background to be steady and not contributing to the changes in the blood sugar. So a pure event, let's see if we can find one. Here's one example of what may be considered a pure event, but I wouldn't consider it 100% pure because those are hard to find. So this is the morning bolus for breakfast. Oh, by the way, this is the data view in Tidepool. So for those of you who are not familiar with it, just go quickly with it. And what we will see here is that Tidepool is basically a software platform that can collect data from pumps and CGMs, or any pump and any CGM, and put it together. And the standard view for this for each day of the week that we will actually see, this is not a 1 day, this is half a day from 5 a.m. to about 6 p.m. But usually we see the entire day, and you're going to see that in the next few slides. But just to illustrate here, we have the CGM tracing up here, obviously, and then we have the grams of carbohydrates here in the yellow circle, 30 grams. And then this is the blue column indicating the bolus. And if I hover over it in real time, when I'm actually looking at the website, it will tell me that how much was this dose, this 2.6 units, and the exact time and the carb ratio that we use to calculate this, etc. And again, we're going to see some examples of that. And at the bottom here, we will see that this is the basal rate. So obviously, this is a patient who's using a closed loop system, and the basal rate is being adjusted as we go continuously. But when we see this here, there's no dotted line. The dotted line is overlapping the solid line. That means the basal rate that's set in the pump is what's running, and the closed loop system did not adjust it. Here, it increased it a little bit. Here, it decreased it quite a bit, actually shut it off 0% basal for about 15 minutes or so. And again, in real time, if I hover over it, it will tell me how much and how long it exactly did. So that helps us calculate how much extra insulin was given. For example, right here, this is a big increase in the basal, almost quadrupling it. And if I hover over it, I can probably guess close enough to say how much extra insulin was given right here in addition to this bolus right here. So is this a pure event? Well, it comes close. It's a single dose for a meal in the morning right here, 30 grams and 2.6 units. Preceded by a stable CGM trace for at least 1 hour. We actually have almost 3 to 4 hours here of stable CGM, so that's really good. The basal rate was working well before waking up and eating breakfast, and followed by no events for 3 to 4 hours. And I would say that we almost got there, but not quite. We don't have a full 3 hours before the next meal. We actually have only 2 hours and about 30 minutes or so. So we didn't meet the full criteria, but I think it's okay because this is still helpful. And then the fourth criteria is that we have a good stable basal rate in the background. And I think we do, with some changes here in the basal, some changes here in the basal. But these changes kind of nullify each other. We see that 0 basal here and increased basal there. So it's not exactly, big changes in the basal. So I think this would qualify. Sorry, I'm going to go through this animation again. Qualify as a semi-pure event that gives us an indication that this bolus of 2.6 units for 30 grams was not enough to cover the carbs because the blood sugar was rising and was still rising before the next meal came in. So this is a suggestion that the insulin-to-carb ratio may actually not be enough. So it's too weak of an insulin-to-carb ratio for this meal at this time of the day at 10 o'clock in the morning when this patient ate breakfast. All right, what about this one, pure event? I'm going to give you 5 seconds to look at this to see if you can identify a pure event in this slide right here. This is a full day, 24-hour of one person who is not using a closed loop system. All right, 5 seconds are over. So let's see if we have a pure event. I would say, yes, we do. We have not 100% pure event, but it's an event with a correction bolus right here. This is the tiny one, but it's really helpful and useful for doing our calculations. We have a correction bolus, we have a steady CGM in the previous 2 or 3 hours, and then nothing else is happening. The patient was still sleeping because it was her father who gave her the bolus at 4:40 in the morning, and then BG was dropping and there was nothing else happening. Again, it didn't quite reach the 3 to 4 hours post-bolus of no other events. This was only about 2 hours and 15 minutes. She woke up and ate breakfast, but that's okay. We can still use this information here, which basically tells us that this bolus kind of started to work and was working okay. And if we had let it go for another hour before she ate breakfast, it probably would have hit the target and maybe even a little bit lower. Remember, this dotted line is always 70 and this dotted line is 180, and that's the range that we aim for here. And anything that's in this range is going to be in green, and anything above is purple. All right, how about another event? For those of you who identified this bolus as a pure event, good for you, because that is another pure event that would be very useful to look at. So we have a bolus for carbs right here. Blood sugar went up and went back down and went back down to baseline. And for 4+ hours, there was nothing else going on. No other events, no other boluses. And we have a nice steady basal that's actually working pretty much with no adjustments, no changes, except for a little suspension here because she was dropping a little bit too close or too fast. So suspended the pump, resumed the pump within 10 minutes. So no major changes in the basal, and a good solid working basal rate, because we can see how nicely working it is during the night. And if it's working this well during the night, I would expect it to be working fairly well during the day as well. So we have a good criteria for this event to be a pure event to calculate the insulin to carb ratio. Was this bolus enough to cover the 48 grams? We're going to get back to that in a second. And here's another event right here. Again, this was not a completely pure event, but we have a 1 hour preceded CGM tracing that's steady. And then we have a single bolus, but it's a component of a bolus for the carbs as well as a bolus for a correction because her blood sugar was high. So combine those two together, we have a single bolus, and then we have nothing else going on for the next 5 hours. And then at the end of the 5 hours, the blood sugar actually starts to go steady right here. So the effect of this bolus finished right here at about 4.5 hours. Again, we're going to get back to that in just a second. So let's get back to this, which is try to dissect it and decipher it. That very first one here to calculate the ISF. As I said, if we hover over that, it tells me that the starting blood sugar was 162 at 4:41 a.m. And based on an ISF of 35 and a target blood sugar of 100, it delivered 1.77 units. And a starting blood sugar of 162, and 2.5 hours later, it was 108. But like I said, if we let it go for another hour, it probably would have gone down to like 95 or let's say 92 to make the calculations easy. So let's say this would have been 92, 162 minus 92, which is the effect of this bolus of 1.77. So we have 70-point drop with 1.77 units. And if we do the math, that's roughly about an ISF of 40. 1.77 drops you 70 points, 1 unit drops you 40 points. So that means the ISF for this patient at this time of the day would be somewhere around 40. So we can just let go and say, we can't make a decision or a change based on a just single event. We have to find 3 or 4 different events, do the same calculation, take the average result that we're coming up with and say, it looks like your ISF is a little bit too strong here at 35 at 4 in the morning. So maybe we should change it to 40 if we have that consistent finding. I wish I could say, are there any questions? But I think, obviously with webinars, we can't do that.
So we do have a couple of questions that are coming in, but they're a little general. I can throw them at you if you want right now, Dr. D. How do you feel about that? You want to wait till the end?
Let's do another 5 or so minutes, and then we'll take a break and field some questions. Okay?
Sounds good.
All right. So just to finish the story from this slide here, we have the second event here that we identified, which is right here. We have this bolus for 48 grams, and I think we hinted at that earlier, is that this is a good one to assess, was this bolus enough for the 48 grams? And when we hover over it, we'll see that there was no blood sugar entered here. So that means there was no correction for the blood sugar because it was right at 108. There's no need for a correction. So this is a bolus that's just for the meal of 48 grams. There was a tiny little bit insulin on board left, 0.66 units from this correction bolus 2 hours earlier. So we're going to ignore that a little bit. But the point is we have a pure 9.6 unit bolus based on an insulin to carb ratio of 1 to 5 grams and 48 grams total. And let's see what happened here. We start out with a blood sugar of 108, 48 grams, 9.6 units, and 4.5 hours later, the blood sugar is back down to exactly where it was at baseline, which means that this bolus, 9.6, was perfect for covering the 48 grams. And it did so in about 4.5 hours. It took a while. And it's interesting to see how the changes in the blood sugar here with the CGM is sort of just reminiscent of the action of insulin, how it's sort of, it has a peak effect here, and then it starts coming down, and then there's a tail of insulin after 3 hours, but it's still sustained for another hour, an hour and a half after that. So that really, if this is a good one to sort of calculate or approximate the insulin duration time. Even at 4 hours after the bolus, it was still doing something. So in this patient, I would say if if I'm going to put the settings in the pump, instead of doing the typical 3 hours, I would say 4 or even 4.5 hours for this patient. All right, and then finally, this is the last one. Again, we sort of just briefly talked about it, which is a combination of a correction, because we have a blood sugar of 288, and then we have a carb meal of 32 grams, and the combination of both is 12 units in 28. At the 12 units in 12.28 units, sorry. And then the insulin-to-carb ratio is 1:5, and the ISF is 32, and the target is 100. And the combination of the correction and the carb bolus worked beautifully for about 4.5 hours. Again, at 4.5 hours, the line became flat, indicating that the bolus is finished working here, emphasizing that the insulin duration time is really closer to 4 and 4.5 hours, just like we saw there. So I would definitely go for the 4 to 4.5 hours for insulin duration time, not 3 hours, not 5 or 6 hours. It's really about 4 to 4.5. All right, how about this event? This is the same patient the day before. Is this a pure event? And I would say the answer is no, because we don't have a steady CGM before that. There was a missed bolus here for a meal 2 hours before that. Blood sugar is rising. And even though we have a correction dose right here, but I don't think we can use this to calculate the correction dose or to assess the correction dose. Did it work or not? Because we don't have all the other elements of what I would consider a pure event to make a calculation. This one, however, at first you would think that this is not a good one to look at, but in fact, it's actually quite helpful. There's an opportunity here for evaluating an ISF at 9 p.m. This is now 4 hours after the last meal. There was a disconnection with the CGM, but it picked up. Yes, it's not exactly a stable CGM before, but there is a correction given here. Not a correction bolus, but a correction action by the closed loop system that increased the basal rate right here to say, I'm going to give you extra insulin. And prior to that, we have almost 3 hours with no changes in the basal, and it's working on its own. And then the following 2.5 hours, there was no changes in the basal either. You know, there was just tiny little blip here, but we could ignore it, that's minimal. But the effect here is that this is almost like a bolus of a certain amount that resulted in a drop of blood sugar from here to here. So let's see how that works out. If we hover over that, we will see that the increase in the basal right here actually was running at 2.4 units an hour. So we're going to do it right here. The temp basal was 2.4 units an hour. The scheduled basal was 0.6 units an hour. So the extra basal was 1.8 unit an hour. So the extra basal was running at about 1.8 unit per hour, but it only worked for about 20 minutes. So really, this is calculating that the additional insulin that was given during this 20 minutes by the closed loop system was an extra 0.6 units. So it's almost like giving a bolus of 0.6 units. And that 0.6 units dropped the blood sugar from 160 to 86. And if we do the calculation, that's a drop of 74 points right here. 0.6 units extra, drop the blood sugar 74. 1 unit drops the blood sugar 104. That means the ISF is about 100 to 110. Let's see, can we see that again? Let's just go over it one more time. This is a closed loop system that automatically increased the basal rate here for only 20 minutes, effectively giving an extra 0.6 units of insulin on top of the running basal rate back here. And the 0.6 dropped it from 160 to 86, and that's how we can calculate the ISF for this one. So again, even though this wasn't a completely pure event, but it was helpful in calculating the ISF and making a note of that. And we look at 2 or 3 other events, and if we come up with the same result, we can confidently say that the ISF should be about 100 to 110, at least at this point of the day again. All right, Christopher, you want to shoot some questions?
Sure. Oh, wow. They are coming in. All right. We got a couple from Anonymous. Thank you, Anonymous, out there. In looking for pure events, how far into history is it useful to look, especially for a child? Is the 4 to 6 week range the sort of outer limit for looking for pure events?
Yeah, that's a great question, and I actually meant to make that point, but I forgot. So thank you for reminding me. The answer is I would go back 2 to 3 weeks before today. Like if I'm interpreting the data today, I typically go for the past 14 days, and I think that's still relevant, the past 14 days, because it's, you got to look deep and hard to find those events. But I wouldn't go more than 2 weeks from now because things are changing with these children.
Okay. Thank you. I feel like we could just have like a question specifically about the concept of pure events. Another one in from Amin. Thank you, Amin. With regards to physical activity, does that mean the person should not be moving? Like, what do you define as physical activity whenever you're considering whether or not that's going to be impacting?
Yeah, good question, Christopher. And I mean, this is physical activity, meaning not going out for a run or not going out for a soccer practice. We're not doing that these days. But walking the dog. I know somebody who drops his blood sugar 150 points every time he walks the dog.
Guilty.
So those kinds of activity, but not sitting around doing nothing, obviously, just normal sort of day living activity. It's or going to school or doing homework. That's perfectly fine.
All right, we'll do 2 more here, and then we'll let you get back to the slides. Another one from Anonymous. Thank you, Anonymous. How should you determine the time range that you're looking at to see if a dose works? 2 hours after eating, 3, 4, 5? What sort of range do you give? I mean, obviously, the insulin pump is going to have the insulin duration programmed into it for its calculations and things like that. But whenever it comes to you evaluating things, how much time do you give after an insulin dose to determine the effectiveness?
Yeah, that's another great question and very helpful. For me to sort of illustrate that. Most of the times I follow a general rule, which is that the younger the child and the smaller the dose, the less insulin duration, the shorter insulin duration. So when somebody's taking 25 units of insulin, that's going to last 4 to 6 hours. When somebody's taking 0.7 unit of bolus, well, that's barely going to last 2 hours because it gets absorbed very fast from under the skin and reaches the blood circulation. So generally speaking, I would go for roughly about 2 to 3 hours in children. If we're talking adolescents and post-adolescents and young adults, we're going for 3 to 4 hours, sometimes longer if the doses are big. But a quick look at the CGM tracing in Tidepool and just going over those pure events, one will easily find when did that bolus start working, when did it peak, and when did it actually end. And I think we've shown, hopefully I've shown a couple of examples where you can see that here's the bolus, and then 4 hours later, the CGM tracing, instead of starting to drop, and then it becomes flat after that. That's a good indication the bolus has finished working. And that's a good indication where you should stop looking at this. But generally, I would look for the following 3 hours as a big ballpark, 3 hours after the bolus. All right, so let's get back. Thank you, Christopher. We can take another break in a few minutes for some other questions. Here's the concept of combined events. So again, if we can't find just a single event with nothing else, after or before, then if we have 2 events in a row, but they meet the criteria because we have a steady CGM before that, then we have a steady basal rate across the whole time, and there's nothing. We have almost 8 hours with no action after that, after this meal here, and the next one comes 8 hours later. Well, that's a good one to look at. We combine these 2 and make them into a single event, and you say, okay, what happened to the blood sugar after this? And we can see that the trend here is really going up, actually, suggesting that the insulin-to-carb ratio for these 2 meals was not enough. Now, do we know which one wasn't enough? Is it the breakfast ratio of 21 grams here, or the bolus for the 45 grams here, which happens after 9 a.m.? This isn't a 9 a.m. line. So the ratio typically in children, again, we change the ratio to breakfast before 9 a.m. and most people eat breakfast before 9. And then after 9 a.m. we change the ratio. So is this ratio different than this? Which one is not enough? We can see that actually it's going up, but we don't know which one is not enough. And we just have to look at it another day and say, we have a sense that the insulin-to-carb ratio is not enough, but let's find another event where it might tell us And we don't have to go too far because it's right here. In the evening at 6 p.m. for dinner, there's a 59 gram and a bolus for that. And yes, we don't have a steady CGM for an hour. We have a drop here, but before that, it was pretty steady, going nicely here. So there's not much exercise. There's not much effect of a basal rate. There's no other boluses right here. And we can see that after dinner, the trends is going up again. So perhaps it's the daytime lunch and dinner carb ratio that's not enough. And we can make this adjustment. So we look at this and we say, what's your carb ratio for this one? And then let's make an adjustment based on that. And then we can come back another day when you say, can we find a day when you had only breakfast and nothing else within the next 3 to 4 hours? And then we make an assessment for the breakfast ratio separately. And I hope this kind of makes sense. All right. Where's this one? Evaluating ICR combined events. Again, just a general quick look at the combined events. In the previous slide we had 2. Right here we actually have 3 all together, clumped together here, but no other events for the next 4 hours. No big changes in the basal rate here, even though with the closed loop system. So that's an indication, as a general sense, that the insulin to carb ratio, the boluses for all these 3 meals was actually pretty good, and it worked really nicely. And again, snacking and eating and bolusing, and it's all in green right here. So big sense of insulin to carb ratios are working just fine in this patient, and the basal rates are working just fine at night. This is midnight right here, and you can see that the basal rate is working great, actually. So we don't need to make a lot of changes. We just congratulate these patients and say, you're doing great, you're doing awesome, counting the carbs and bolusing for everything. All right, how about this one? This one is to illustrate that it's not just for pump users, even for those who are using MDI. So this is a patient who is using long-acting insulin and short-acting insulin for meals, and doing so 3 to 4 meals a day. And if we look at the numbers before each meal, they're right here, they're right here, they're right here, and then going to bed is right here. All these numbers are right in the target green zone, and they look great. But in reality, when you look at the CGM tracing, actually it doesn't look that great. This goes up and then comes back down. This goes way up above 300 and then comes back down, 6 or 7 hours later. And the same thing is happening here, suggesting again that the basal insulin, the long-acting insulin dose, is really what's bringing this patient's blood sugar here. It's not the bolus. It's not the insulin for the carb dose here that was given, because this, it can't possibly be lasting 7 or 7.5 hours, bringing the blood sugar down later. These are 2-hour increments. So this is clearly an effect of the long-acting insulin. And the reason the blood sugar is rising so fast here, because it's not enough insulin for the carbs. So the short-acting insulin injections are not enough, the insulin to carb ratio, and the long-acting insulin is too much for this patient. So we make an adjustment and we say, let's lower your long-acting insulin. And now we see that the nighttime is actually nice and steady. So the long-acting effect, or the so-called basal insulin, is now working much better than before. And because we eliminated that effect of the long-acting insulin, now we can demonstrate and uncover the inadequacy of the insulin to carb ratio. And you can see that after each meal, blood sugar goes up and it ends up higher. Blood sugar goes up and ends up higher. Blood sugar goes up and ends up higher. So higher and higher and higher after each meal, clearly saying that the insulin to carb ratio is not enough, and we need to make an adjustment in that. All right, where are we now? Not enough insulin for carb ratio. I think just a general quick look here without calculations. Every time we eat, we have the general trend is higher blood sugars. 20 grams here, 20 grams here, and we end up actually going higher. 30 grams there and 16 grams there and higher. And notice that even though there was no bolus for this 30 grams and no bolus for this 15 grams, but the reason I'm comfortably saying that the trend is going up higher and it's not enough insulin for the carbs is because the basal rate was, increasing this whole time in the entire day, tripling and quadrupling the basal rate and still not keeping up with it, and ending up finally in the purple zone later on. General sense that the insulin to carb ratio in this patient is probably not working enough. Look, after breakfast, 10 grams a bolus here, and it went up and up and up and up, and it was not coming down. until this basal increased, and finally it just kept it from going any higher. But what's happening here is that the basal rate may be a little bit too much. It's actually dropping here at night, and it's shutting off the basal continuously for several hours at night. And we see that repeatedly night after night, suggesting that the basal rate is too much, but the insulin to carb ratio is not enough. And this is a common phenomenon I see in people who actually start on a closed loop system for the first time in the week or two right after they start, that when they were taking injection, they were actually adjusting or compensating for the not enough insulin for the carbs by increasing the basal rate. But in reality, once they go into closed loop system, they will realize that the system is just shutting off that basal the entire night here, suggesting that it's too much. And what they really need is more insulin for the carbs. And then with the safety of a closed loop system and shutting off the insulin, we can be a little bit more courageous in increasing the insulin to carb ratio. And again, in children, small children particularly, like this one, in a 5-year-old, when I see a lot of people just using insulin to carb ratios of 1:60 or 1:50 grams. And I'd say even in the smallest child, 1:60 grams or 1:50 grams will never work. It's actually 1:15 and 1:20 grams, even in an infant or a toddler. And oftentimes when they go on closed loop, we actually uncover that and we start being more aggressive with the insulin to carb ratio. Here's another one, just steadily rising BG and not enough insulin to carb ratio, suggested by the purple line here that you end up with, just a trend going up all the time. And also look at what's going on. The insulin, the closed loop is increasing the basal rate almost all day and all evening. And despite all of that, and despite all of these boluses right here, it's still not enough after a big 72-gram meal. And you can see that strongly suggesting insulin to carb ratio that's not enough. All right, for the sake of time, I'm going to skip this one. But basically shows that in someone who is using a closed loop system, it's not enough to just look at this right here and you say, look, it's going up and it's coming back down. That means the insulin to carb ratio is working okay. There was a meal here, it's just not showing the carbs. But even though this bolus worked okay, but it wasn't just the bolus. It was actually the basal increase that added to the bolus. And with each meal, we see that there was a bolus, but there's also an increase in the basal. Almost every time, there's a significant increase in the basal added to the bolus effect to keep the blood sugar from rising higher, to bring it back down into the green zone. So clearly, again, suggesting that needs more insulin for the carbs because the basal rate is needing to be increased every time there's a meal. All right, so let's see how we can evaluate the insulin to carb ratio. Again, here's a pure event. That's a very nice event right here, where there's nothing going on. And the insulin to carb ratio, the insulin bolus, the bolus for the carbs worked beautifully here, and the blood sugar is nice to target. Again, after each one of these, it's generally speaking not bad, and especially for breakfast. Maybe you can see a trend rising a little bit higher here. The more he eats, the higher he goes, and finally hit the purple here, suggesting that perhaps the insulin to carb ratio for breakfast is working well, but the insulin to carb ratio for the rest of the day could use a little bit of an increase right there. And that's also, illustrated by increasing the basal rate on top of the boluses. So maybe, yeah, he does need a little bit higher insulin to carb ratio. And I think there's one other opportunity here, which is called the pre-bolusing. We always look for those opportunities. We do the calculations, but it comes back to behavior and just connecting with the patients and demonstrating the positives and showing them what's working and what's not working. The reason this is working so beautifully with the breakfast here is that because there was a nice pre-bolus for the breakfast. And I'm going to blow that up in here and show you that this is the bolus here for 41 grams given at 7:46 a.m. And if you look at the CGM tracing, you will see that the blood sugar started rising here very quickly at 8:14 a.m. So this is really when he actually ate the breakfast, but he bolused 30 minutes before breakfast. And because of that, there was no big spike after breakfast. The insulin was ready, it had enough time to work. And we end up with just a little spike in the green and then coming back right down to about 100 in target for the next 2 or 3 hours. Again, going over this and showing them that it pays off and to see this and provide the positive reinforcement and the visual impact of no purple, no red, it's all in green and it's working beautifully. And the insulin to carb ratio and the corrections work very well in this patient. There was actually a little bit of a correction here, even though it's in range, but because it's around 150, there was a tiny bit of correction. All right, so how do we calculate the insulin to carb ratio? We have 10 minutes. Let's go over a few examples of that. Let's see, 30 grams for this bolus, because this was a double bolus, 15 grams here and 15 grams behind it. So the total was 30 grams. The total, the two boluses combined was 1.9 units. And then the blood sugar went up and it required another bolus of 0.9. 0.9, this is a correction one to bring it back down to where we started. And we can see that the combination of this and the extra correction bolus here and the extra insulin basal that was given here, combined, all of these things were enough to cover the 30 grams that were eaten here. And that's basically what says all of this insulin was just right to cover this meal, to cover the 30 grams, because the blood sugar went up and went back down to where it started. It started here and ended up almost at the same number. Nice level line here. So all of these together combined cover the 30 grams. So what do we do with all of this? 1.9 and 0.9, that's 2.8. And I actually estimated that this was an extra 0.2 to 0.3 unit of extra insulin, extra basal that needed to be given right here. This is closed loop that's responding to the spike in the blood sugar. And combined together, this was about 3 units all together. 3 units for 30 grams were perfect to cover it. That means the insulin to carb ratio is 1 unit for 10, not 1 unit for 11 like it actually, or I think there was 12 in this case. So 1 unit for 12 is too weak, and it looks like 1 to 10 should be about right. And we change the insulin to carb ratio to 1 to 10. And for the next day or a couple of days later, we got 25 grams breakfast, 2.5 units for the breakfast, because that's 1 to 10. And there was no other boluses after that, no adjustments in the basal rate after that. It was just the set basal in the background. And blood sugar went up and came back down to almost where it started. Not quite, so perhaps can use a little bit more, maybe 1 for 9, but we'll leave this for now because I think we gotta look at other days and see if it's working or not. Not too bad, again, looks pretty good. We look at the, a few days later, we actually look at 2 days in a row, and it looks like it's working. Again, here's the breakfast ratio, here's the lunch ratio, and it seems like it's working just fine. Maybe a little bit more here. This one looks like it's working just fine again. So I'm actually happy with this, and I'll just leave it alone. 1 to 10 seems to work okay. 1 to 10 seems to work okay. 1 to 10 or 1 to whatever it was here. I can't remember. All right, how about calculating the ICR with this example? Now, this is an older child, an adolescent who wakes up in the morning, has a very nice steady basal rate here, working out all night, wakes up in the morning, eats a little snack in the morning, and forgets to bolus for it. There's no bolus, blood sugar rises. And then at lunchtime, she eats 40 grams, and then she gets her bolus. This 40 grams actually included this bolus included an insulin dose for the 40 grams, and included a correction. I think let's make sure we confirm that. Yes, bolus included 8 units for 40 grams, that's 1 for 5, and a correction of 2 units, but combined together, let's see if we have that red line over there. Yes, combined together, this bolus total 10 units was enough to cover the carbs and bring it right back down to where it started. Yes, it was not effective to bring the blood sugar all the way down to target here. It wasn't enough to bring it down, but the reality is that the combined 10 units, the 8 units for the carbs and the 2 units for the correction, total together was perfect for covering all of the carbs because the blood sugar went back down to where it started. That gives us an idea that 10 units is good for 40 grams, not 8 units, it should be 10. So instead of 1 for 5, this patient actually needs 1 for 4. And we can try 1 for 4 grams and see if that works any better. But again, not just one event, look for 2 or 3 more events like this and confirm that the calculation is really 1 to 4, and then change the insulin to carb ratio.
Right, Dr. Adi, we've got 6 minutes left and like 4,000 questions in.
Okay.
Do you think we can do a couple of questions and then close it out? I know that we've got a hard stop at the end of the hour for this webinar, which is unfortunate considering how involved the audience is. Thank you everybody for all your questions. Do you have time for a couple questions real quick?
I think that, you know, we covered the ISF calculation pretty well. Let me just see, and I think we covered the ICR calculation pretty well. So let me just run through the slides quickly and see if there's another emphasis on the ISF calculation later. And we'll take some questions. No, this is all okay. Just bear with me. Okay, we can skip this because we talked about it in the other. Yeah, I think I'm almost done. So this is just to illustrate that you know, there's no sense of you know, calculating anything here. What we need to work on with this patient is just bolusing for all the meals. So in summary, the CGM is awesome. Without the CGM, we would never be able to do any of this. Detailed daily views can be full of actionable information, and then fix the basal rates first. If you don't have the basal rate working just right, you're never going to be able to tell, is the insulin to carb ratio not enough, or is it the basal that's not enough? And there's no way to tease those apart. So do the basal first, and then attack the insulin to carb ratios and the ISF. And then look for pure events, not just one event, like I said, 3 or 4 times in a row. And even with automated insulin delivery, we still need to review and optimize all the settings. And I hope that I've convinced you that interpreting diabetes data can be rewarding and fun. I actually love it. And it's become more science than art. You know, we used to think that managing type 1 diabetes and adjusting insulin is more of an art than a science, but now I think that's not true because we have the data. And if we look deep in the data and we spend the time, we'll actually, there's a science to it. It's not just art. And then finally, I'm going to leave you with my personal email address, and it will be posted on the last slide. So anyone who has any particular question that we cannot get to today, please feel free to email me anytime. Shoot, Christopher.
All right, so a lot of questions come in. Most importantly, people are asking for more of this, so we will bring Dr. Adi back for this, I promise. This is always good stuff. There were a couple of questions that came in that were revolving around the same general concept of, like, what if my carb counting is off? Like there are a lot of, there's some sort of underlying fundamentals that become assumptions whenever you go to evaluate the data. When it comes to something like understanding the impact of exercise, or like what is the extent of physical activity that would not be overwhelmingly impacting your blood glucose, or the accuracy of your carb counting, these other fundamentals there. How do you approach those sorts of core concepts before you get to evaluating the data to know if settings or adjustments need to be made around insulin therapy?
Yeah, those are really, really awesome points that you're making. And the answer is, no, you have to pay attention to that and you have to address that. So when you're doing calculations based on those numbers that you see in the pump, you kind of have to just know your patient. You got to trust them. You say, okay, who's counting the carbs? And usually what I have done in the past, and I say, listen, you know, sometimes you just look at things and you say, it just doesn't make sense. And actually there was one case in our slides today that I forgot to bring up because we were speeding through. But in one case, it was very clear that, you know, there's no way that the insulin to carb ratio was not enough. You just didn't count the carbs right, or you didn't estimate the carbs right for that meal. And that's why you ended up so high. So, you know, general sense of looking at the data, you get a sense of, whether the carb counting seems to be a problem occasionally or not. And usually what I do when I feel that way is that, because I know my patients, is I ask the parents and I say, look, can you please just pay really close attention. Make an effort for the next 3 or 4 days of making sure that you're counting all the carbs and measuring and weighing, not just estimating. And pre-weigh everything and pre-count everything and put them on the table and label them for your child so that they have a snack that's already calculated. And you know for sure it's close enough of a carb count, because we're going to need to rely on that for calculating the ISF and the ICR. So it's important to know your patients, to trust them, and then and don't feel bad about asking. You say, for the next few days, I'm going to ask you for some extra work. I need you to do this for me.
I think that's going to be a good point to leave it on. There are a lot of other questions that are actually really specific around things like insulin duration, logarithmic scale around insulin activity, things like that. Again, we posted Dr. Adi's email address here. That final slide has it. For anybody that didn't get it jotted down, we're recording this webinar. We will be publishing it tomorrow, and I'll be sending out an email with everybody to everybody who's registered to attend to review everything that's been covered, as well as Dr. Adi's contact information if you have anything else you want to share there. So again, thank you all for attending. As a quick reminder, diabetestelemedicine.org is a website to go for all your telemedicine related resources as it relates to Tidepool. How many more times can I say relates? But most importantly, this COVID thing isn't going away anytime soon. Telemedicine is the present and the future. Diabetestelemedicine.org. When in doubt, as mentioned, support@tidepool.org is the email address. If you have any questions about anything you've seen here or anything else related to Tidepool, send an email there and we will get back to you. And also, we have a whole host of other webinars that we've done over the past few months. If you go to tidepool.org/webinars, most importantly, this one over here from Dr. Adi in May on basal testing and optimization. That was a real hit. So start there in terms of building out your foundation of understanding all these settings and how things can go from there. And then you can come back to this one again and re-up on Dr. Adi's magic and wisdom as it relates to that. And then stay tuned, I guess, for another one of these webinars because the crowd has clearly spoken and they want more of this stuff. And lastly, in case for those of you that weren't aware, Tidepool is actually a nonprofit organization. And while we are dedicated to reducing the burden of diabetes management through the software that we make for people with diabetes and their care teams, we are working hard to make sure that our users can upload, view, and take action based on their own data. Also, in case you haven't heard, we're working on this thing called Tidepool Loop. This is our effort to build an FDA-regulated version of Loop. That was originally a do-it-yourself project that was made by some really, really smart people out in the diabetes community. We're taking that through our process, taking it to the FDA, and it's kind of a big deal. And we can't wait to actually share more about this as our work progresses. There's a lot to talk about. And I look forward to being part of that communication out with the entire diabetes world because it's a really awesome thing. And I guess lastly, throughout the years, the support of the community, people like you out there watching this has been actually essential to Tidepool progressing over the years. It's over 7 years now that Tidepool's been around as a nonprofit organization. So if you are interested in learning more or making a direct impact in terms of supporting us one way or another, please visit our website at tidepool.org. There's a big button at the top that says get involved. And you can click on that and see how to get involved. One other way you could actually get involved, I wish I was actually wearing it, you can make a donation and get a cool Tidepool shirt. It would normally have a big T on it. I'm not wearing my Tidepool shirt today. I'm not properly branded, but that's just one of the ways you can get involved and support Tidepool along the way.
The sign is right behind you, Christopher.
Yes. Well, so that is a custom job though, that you can't get that at gifts.tidepool.org. That is just me being a homer. But anyway, it's always a pleasure to do one of these things with you, Dr. Adi. Thank you for taking the time to walk through with this. And I guess I'll look forward to bringing you back on again because the people can't get enough of this stuff. This is really awesome stuff. Thank you again.
Thank you very much, Christopher, and the whole team, and Suzanne in the background. And we'll take all of those questions that came that we can get to, and formulate the next webinar to hopefully address some of those questions.
Definitely. Thank you again, everybody. Have a great day.